So we'll just give people a few more minutes to all log in.
When that job is finished, see up on the wall, big high wall, white wall. So at the end of the job, maybe.
Okay, welcome everyone. In the interest of time, I think we'll open ceremonies. I know that people will be trickling in as we start, but it's really a pleasure to see everyone and definitely an honor to introduce our speakers today. I just want to welcome you on behalf of the UCLA Center for Social Medicine and my co-faculty there, including Philippe Bourgois and Joel Braslau. And I also want to welcome you on behalf of the research team on health equity and translational social science, on behalf of myself and my co-chair, Rochelle Dicker. So welcome to the Rangel and Health Equity Translational Social Science themed seminar. And I will, without further ado, introduce our guest speakers. It's exciting to have them here in Los Angeles. And unfortunately, because of Omicron, we had to do a Zoom session in place of a mixed session as we'd originally hoped, but it's still wonderful to have them here with us on Zoom and also in Los Angeles in close proximity. So I'll start with our first guest speaker. I want to mention that I actually know both of them. I've had the pleasure of being invited by them to work on the Lancet Commission on U.S. Health Policy in the era of Trump. It's been a fantastic experience to see them in action. They are such a dynamic pair of scholars. So I'll start with Steffi Woolhandler, MD, MPH. She's distinguished professor at the City University of New York's Hunter College. She's a primary care doctor in the South Bronx, a lecturer in medicine at Harvard Medical School, where she was formerly a professor of medicine. She's native to Louisiana. She graduated from LSU Medical School in New Orleans and completed an internal medicine residency at Cambridge Hospital. Also a research fellowship in general internal medicine at Harvard. And during her stint as a Robert Wood Johnson Health Policy Fellow at the Institute of Medicine, which is now called the National Academy of Medicine, she worked with Senator Paul Wellstone and then Congressman Bernie Sanders. She's published more than 150 journal articles, reviews, chapters, and books on health policy, and is a leading advocate for nonprofit national health insurance in the United States. I think you saw on our flyer that she and David Himmelstein are co-founders of Physicians for a National Health Program, among other things. And let's see, I just lost my script. Here we are. So among her influential scholarly articles are studies of patient dumping, which led to a federal ban on that practice, medical bankruptcy, which she co-authored with Elizabeth Warren, waste in hospitals and in medicine more generally, and the lethality of being uninsured, with proposals for single payer health reform. And after we hear from Dr. Woolhandler, we'll hear from David Himmelstein, MD. He's a distinguished professor of public health at CUNY's Hunter College and a lecturer in medicine at Harvard Medical School as well, where he was also a professor of medicine. He serves as a staff physician at Montefiore Medical Center in the Bronx, graduated from Columbia University's College of Physicians and Surgeons, completed a medical residency at Highland Hospital in Oakland, California, so California connection, and a fellowship in general internal medicine at Harvard, where he practiced primary care and served as chief of social and community medicine at the public hospital in Cambridge prior to moving to CUNY. He's authored or co-authored 3 books and more than 150 journal articles, including widely cited proposals for single-payer healthcare reform in the New England Journal and JAMA, as well as studies of patient dumping, the high administrative costs of the US healthcare system, and the mortal consequences of uninsurance. So without further ado, I hand you over to your speakers.
Hi, I'm Steffi, and David will be coming on in about 20 minutes. We have no financial conflicts of interest. We have served as unpaid advisors to several presidential campaigns recently, Bernie Sanders and Elizabeth Warren's. As Helen mentioned, we've collaborated in the past and recently on research with Senator Warren, and we did found Physicians for National Health Program. Now, how do we get to where we are? Well, during the Vietnam War, I actually worked at Fort Hood, Texas, organizing anti-war soldiers, anti-war GIs. And this was actually the coffee house that we had opened in Killeen, Texas. And you'll note there are no windows because they'd all been shot out, this being Texas. But we did come of age at the end of the Vietnam War, and it felt like the world as it was unsustainable. So in other words, it was a time a lot like our own. We really are facing what it seems politically unsustainable right now. I went to medical school and started practicing in Oakland. And this is actually a picture from the Black Panther Party. And they had developed this strategy of serve the people, where they were giving free medical care and free breakfast programs to people in Oakland. And I had this concept of myself like I was going to be a people's doctor, take care of the poor people, not practice corporate medicine. And that's what I thought I was going to do. But then I shifted in the course of my training into something I call research-based advocacy, and recognizing that the healthcare system itself was part of the problem, that it was producing and reproducing the inequality in the overall society. And as an insider in the healthcare system, there was a way to expose it and change it. First major project we did was based on a man that I saw at the hospital as a patient. He was a 59-year-old person in a motor vehicle accident. And you can tell this is from before HIPAA. It's also a paper chart, right? This is actually his chart. He had an open skull fracture. He went to an HMO hospital where he had a negative wallet biopsy, no insurance card. He was transferred to the public hospital where I was working with bone and brain visible through his wound. When he got there, we diagnosed a C1 fracture, a neck fracture, which could have paralyzed him, but luckily didn't. He went to surgery. He did very well, actually, but 4 days later, the HMO discovered that the patient was in fact a member and demanded his transfer back to the HMO. So this showed us both how uninsured people might get mistreated, but also how people who have insurance with restrictions and limitations on it might be harmed by the healthcare system. We ended up with other trainees putting together a study of nearly 500 consecutive patient transfers into our public hospital, looking at their clinical condition. We published this. Trainees in Chicago and trainees in Tennessee did similar studies, and it actually resulted in passage of the so-called EMTALA laws, which now prohibit patient dumping from one emergency room to another if the patient has a life-threatening illness or active labor. So actually getting a federal law change got us very excited that maybe exposing some of the problems in the healthcare system could actually be an instrument for change and actually making things more just. Another person I saw, he was a janitor at the hospital where I worked. And of course, at our hospital, all the employees had health insurance, but he was bent over in pain for days and looked like he had a kidney stone. turned out he was a contractor. He worked for a contractor. He didn't work for the hospital. He cleaned the hospital, but on a contract with a private contractor, and he had no health insurance. So I started looking at people within the healthcare system who work in healthcare and have no health insurance. At the time, it was nearly 12% of healthcare workers had no health insurance. But to this day, in places like nursing homes and home care, the rates of uninsurance are about 14%. And we've done several studies trying to expose the injustice of people working full-time in healthcare and not getting healthcare themselves. Now, obviously, this is a subset of the uninsured. The number of uninsured in the U.S. has never dropped much below 25 million. In recent times, it was a little bit below that after the passage of Medicare and Medicaid, but then climbed steadily until passage of the Affordable Care Act. But we're still hovering around 30 million uninsured people in this country. We have a long way to go to get to universal insurance coverage. We've looked several times at issues related to lack of insurance and mortality. This was sort of a complicated statistical look at it, but this is going to be obvious to everyone in the room. I think most of you are close enough to the healthcare system to realize if you're uninsured, you're not going to die right away, but of 1,000 people or so, about one will die over the course of the year related to poor access to care caused by being uninsured. But of course, people who have insurance don't always get the care they need either. The average deductible for a covered worker in this country for single coverage is now $1,600. So for many low-income people, the deductible is what you have to take out of your pocket before your insurance pays a penny. So for many low-income people with insurance, healthcare is still unaffordable. And we do know from the work of other people that uninsured and underinsured persons delay seeking care for heart attacks. Not surprisingly, the uninsured at the far right had an elevated risk of delaying seeking care for heart attacks, 38%. But underinsured people who had coverage but were still worried about costs also had a 21% probability of delaying care. And in internal medicine, we have this little mantra: time is muscle, time is muscle. If you're having a heart attack, you need to be in the emergency room immediately to get those clot buster drugs or other treatments that can save your life. So delay is particularly serious. Other scholars have looked at charging co-payments and what that does in terms of patients taking their medications that they need to stay alive, to prevent heart attacks. And in fact, adding co-payments on drugs does in fact kill people. In this particular study, quasi-experimental study, mortality went up nearly 32% among the group who had new co-payments added to their medications. Now, we talked a little bit about work with Senator Warren on illness and injury as contributors to bankruptcy. She's mostly moved on to other things, but we continue to work on the issue of bankruptcy and medical debt as serious contributors to poverty and financial insecurity in this country. This is from the work we had done with Senator Warren. You probably know the bottom line of the work we did, because it was publicized by Obama and many others, that medical illness and medical bills are a leading cause of personal bankruptcy in the United States. You may be less, and that was our major finding, right? But you may be less familiar with this particular finding, which was the majority of people entering personal bankruptcy had coverage, at least when they first got sick. They were, sometimes they lost their coverage, but most of the time they held on to their private coverage throughout the bankrupting illness, but were bankrupted anyway by co-payments, deductibles, and uncovered services and other gaps. So a very serious problem. We updated this recently with some Census Bureau data that actually over the last 3 years, the Census Bureau did a survey that asked about medical debts. They've actually never done that before. And we found that about 10.8% of adults and 18.1% of US households carry medical debt. 1 in 10 adults, 1 in 5 households, which often have multiple adults, right? But looking at who is more likely to have these medical debts, if you're female, you're more likely to have them. If you're Black, if you have high deductible insurance. As I pointed out, a very high share of Americans now have high deductible insurance. Or if you live in a Medicaid non-expansion state. We were able to look at predictors of medical debt after we control for a lot of factors, obviously most prominently income and change in income over time. This is a longitudinal look at the 3 years of data. The biggest predictors of going into medical debt are, unsurprisingly, you got hospitalized, you became newly disabled, or you had health insurance and you lost it. Those were our biggest predictors longitudinally of acquiring new medical debt. But then we turned this around, inverted it and said, okay, once you have medical debt, what does that predict in terms of social determinants of health? In this case, food and housing insecurity. And it turns out that newly acquiring medical debt during the study was associated with newly becoming food insecure with an odds ratio greater than 2. Similarly, newly being unable to pay your rent or mortgage was predicted by medical debt. Being unable to pay your utilities where you had been able in the past, and actually being evicted. So we have sort of turned the concept of social determinants on its head, where the healthcare system treats you for illness and puts you into debt in ways that create new social determinants of ill health. This is unpublished. We actually just submitted it for publication, but I think we are far from having solved the problem of making healthcare affordable in this country. Now, I want to talk briefly about the Lancet Commission that Helena sat on with many other people. We published it early in 2021 in the Lancet. It was about half of an issue of the Lancet. But in it, we talked about Trump's 4 years of health harming policies and what the Biden administration needed to do to start reversing them. We talked about the 40 years of what I'd call neoliberal policy failures that undermine the conditions needed for a healthy population. And of course, we also talked about 400 years of genocide and white supremacy that breed health inequality and actually poisoned the US political milieu. We went into a lot of areas. We looked at occupational and environmental health, which did in fact deteriorate rapidly under the Trump administration. I'm not going to go into that anymore, but I want to focus some on the issues of racism that has been a long-standing problem in the United States and a major harm to human health. Certainly, we have a lot of structural racism in this country where Black people as a group represented in yellow have much lower incomes and total resources than white people on average. So we start with that structure of racism where Black people are often poorer. And that, I think, is a cause of the huge differences that we see in life expectancy. We've graphed the average life expectancy in other affluent countries in the G6 on the top with that little dotted line. But every group in the United States has lower life expectancy than the average person in other wealthy nations, with the lowest life expectancy being among African American and Native American people. Again, structural racism. And with the COVID pandemic, we've actually seen this situation get worse, so that white population has lost about 1 year of life expectancy, but among Latinx and Black Americans, there's been about a 3-year loss of life expectancy from COVID, really quite catastrophic. But I want to remind you, most of the deaths are not, COVID. Most of the mortality gap, and in this case between Blacks and whites, are things that the medical system can do something about: heart disease, cancer, stroke, renal disease. So we have these long-standing problems. And one of those long-standing problems is that minority people in the United States get less health care. And this is from the Lancet report. White people get, based on the dollars of utilization, get much more health care than minority people. We've done work over the years looking at race and ethnic disparities in all sorts of care. This one's about, particularly evocative about the lack of mental health care for children and young adults in the United States among racial minority youth. We do know that the racial minorities in this country are much less likely to have health insurance. And that lack of health insurance and the fact that when they have insurance, it's more likely to be Medicaid rather than private insurance is a major driver of structural racism in the delivery of care. So if we look at the reimbursement for inpatient day at a Black serving hospital, a hospital that's in the top 10% of US hospitals in terms of the share of Black patients versus other hospitals, the per patient day reimbursement is almost double in other hospitals relative to Black serving hospitals. A tremendous gap. And you won't be surprised to hear that most Black serving hospitals run at a deficit of about $170 per patient day versus a profit for other hospitals. So our insurance system becomes a structural problem in that you get lower reimbursement in hospitals that serve large numbers of poor and minority people. And this is actually looking at not just Black serving hospitals, but Latinx serving hospitals, how this translates into capital, into the buildings and equipment that the hospital has available to take care of people. And hospitals that serve mainly white patients have much higher value buildings, much higher value equipment, much more in the way of high-tech services than hospitals that serve white and Latinx people. Again, structural racism, really in concrete. If you have a racist way of paying for care, it trickles down and causes the hospitals that serve racial minorities to have fewer resources, as a basic structure of inequality. Indian Health Service, similarly, very underfunded relative to what they need. Their funding is only about $3,000 per person per year, which is about a third of the average cost of care in the United States. The other deficit, of course, is in minority professionals. We have a real dearth of Black health professionals, particularly in higher paid fields such as dentists and physicians, advanced practice nurses. But of course, many minority people work in the other parts of the healthcare system, in the middle and lower paid parts of the healthcare system. Gee, I thought I had one for oh no, here we go. What's the problem with this? The problem with this is that when minority people go into an institution, they like to see other minority people. They trust those people more, often based on their past experiences of racism within the system. But this was just a very good experimental study, and it turns out if a Black person goes to see a white doctor, they may like them, but they won't take their advice to the same extent to which they'll take the advice of a Black physician. Okay, and this is our data on Hispanic people in health occupations. And again, Hispanics are underrepresented in almost every health profession with the exception of medical aides and assistants. A couple of other issues that we dealt with in the Lancet report. Obviously, the problem with fairness to immigrants is largely a racial problem in the United States. And I love this joke, which a friend of mine who's 95 years old went to a demonstration and took this picture. We also have been very concerned about the healthcare of prisoners and folks in detention, which again has very strong racial overtones. Now, I want to very briefly to introduce what David's going to talk about 40 years of failed policies and how they've created this. And I would call these neoliberalism. Neoliberalism became dominant in the United States around 1980. There's a complicated term because neoliberalism isn't new and it's not liberal. It's old and it's capitalist. But neoliberalism says markets regulate themselves. They give everyone what they deserve, that unions distort markets, impede formation of merit-based hierarchies. Government is always incompetent. Taxes and regulations should be cut. Public services should be privatized. And seeking equality is counterproductive and morally corrosive. And in case you're wondering, that's Hayek, Friedman, Ronald Reagan, and Margaret Thatcher, who were big proponents and advocates for neoliberalism. But neoliberalism was adopted not just by the Republicans who made like funny jokes, like the most frightening words in the English language are, "I'm from the government, I'm here to help," but also by folks like Bill Clinton, who said things like the era of big government is over. So neoliberalism has become a dominant ideology in the United States. Within healthcare, neoliberalism has meant replacing a nonprofit health system with one that's publicly funded by taxes, but completely privately controlled and for profit. And this has been associated with a tremendous growth in healthcare spending. So neoliberalism has not suppressed healthcare cost growth. but also with a halt in the progress toward improving mortality. And here's David, he's going to keep going.
I'm going to focus more narrowly a bit on the healthcare financing system and its ramifications. And one of the ramifications I'll try and convince you of is the falling off of the US from the mortality curves of other nations that we would compare ourselves to. So even before COVID, US mortality figures, which were middle of the pack in 1980, have deteriorated relative to other countries. And at least part of this is attributable to inadequate healthcare. So this is very worrisome recent trends in the percent of adults whose hypertension was controlled, and really a bedrock of primary care and prevention of stroke, heart attack, leading causes of mortality. So over the last 5-7 years, we've had an actual marked deterioration in control of blood pressure, really a failing of our healthcare system. The COVID epidemic has shown other shortcomings. So this is a comparison of the change in life expectancy in a variety of nations, and I've graphed the worst on your left, and only Russia has done worse than the US in terms of the average effect on life expectancy. We've lost 2 years, Russia 2.3 years. A couple of other countries actually gained life expectancy as compared to their previous curves during the pandemic, but we've had a horrendous record during this pandemic. If we look at the distribution of income in our country, one of the things that's happened in the neoliberal era is marked increases in inequality. So on your left is the poorest 20% of the population who've seen total income growth over the last 3 decades of 6%. And you see that the top 5% has seen an 118% growth in their income. And if you separate that 5% out into the top 0.1%, for instance, it's much more marked than that. So we've had growing income inequality, and that's been accompanied by growing health inequalities. So this is actually data looking at average remaining life expectancy for men after they turn 60, and looking at the entire population using Social Security records. Back in 1972, there was a 1.2-year difference in life expectancy between the richest half of the population and the poorest half of the population. Poorest half is shown in yellow and richest half in blue here. So 1.2-year difference in life expectancy back in 1972. By 2001, that had increased to about 6-year difference in life expectancy. So markedly increased inequalities. And we've had a similar trend in spending for different categories of income categories in our nation. This is work led by Sam Dickman with our group. And the red is the top 20%, the richest 20% of the population. And this is health spending per person. And what you see is that the health spending per person for the richest 20% was sort of at the low end of all the income groups back in the late 90s. And that's appropriate because it's by far the healthiest group. They need the least healthcare, but they've skyrocketed in their use of healthcare since then. And Sam published this in Health Affairs. Steffi alluded to the fact that our healthcare system is publicly funded but privately controlled. Well, if you add up all of the sources of public spending, so not just Medicare, Medicaid, and the VA, but we've included here government workers' benefits. So when the FBI agent gets their coverage, they have private coverage, but it's paid for by government, and same with police and fire departments and so on. And also the tax subsidies for private coverage. And with those added in, about 2/3 of total health spending in our nation comes from government. So we have a hugely publicly funded healthcare system. In fact, we're at 65% of health spending. Nations with national health insurance are generally between 67 and 70% being government. And much of that money is now funneled through private insurers. So back in 2017 is the most recent good data we've been able to get for this. 52% of private insurance companies' revenues actually came from Medicare and Medicaid. So we have Medicaid programs that are subcontracting coverage to private HMOs, and Medicare through the Medicare Advantage program, where people can choose to have Medicare pay their premiums for a private Medicare Advantage plan. And between those things, back in 2017, it was $427 billion in public money flowing through private insurance firms. It's surely much more now. We don't have precise figures on this. And the extent of for-profit ownership has grown rapidly throughout our healthcare system. We now have 70% of all hospices that are owned by for-profit corporations, 3/4 of home care agencies, and so on. But even in our general hospitals, now 10% of hospitals owned by for-profit corporations, an increasing number held by venture capital firms who are in it just for short-term gain. And I mentioned the Medicare Advantage program, 25 million seniors now enrolled in Medicare Advantage, where Medicare pays their premiums to a private plan. And why is that a concern? Well, the way you profit as a private plan is to avoid unprofitable patients or to kick out the unprofitable patients. And the one way to do that is by excluding doctors who are attractive to high-cost patients. So in New York City, the Banner Cancer Center has no Medicare Advantage plans that have chosen to include it in its network because they're the expensive provider of cancer care. And what we call lemon dropping, so induce the sick to disenroll. So you make your benefits attractive to the healthy and low-cost patients, but through formulary design, so you make drugs that are needed by high-cost patients high co-payment drugs, and you get them to leave. You hassle them. You don't have the doctors they want in your network. Overdiagnosis and upcoding, so we adjust the payment based on how sick the patients are. And the way you can make them look sick as a Medicare managed care plan is to attach diagnoses of minimal importance or severity that raise your premiums, that don't cost you much. So if you do an echocardiogram on all your 80-year-old patients, you'll diagnose lots of heart failure, most of which needs no treatment at all, and you'll increase your premiums by $1,000 per patient per year. And we now have limits on how much overhead those plans are allowed to make under the Affordable Care Act. But the way you can avoid that is to, as United Healthcare does, they own 53,000 doctors. So you pay your doctors' practices large amounts and skim the profits off of that. And that then doesn't count as insurance overhead. So lots of games being played by these plans. Steffi and I have been monitoring some of these games, which are often involve cutting physicians in on the profits for many years. This was a piece we had in the New England Journal of Medicine about our own contracts with one HMO that said basically we're not allowed to disclose how they pay us and not allowed to criticize them in public. So the fact that we were paid to collude with the plan in denying patients the care they needed was something we weren't allowed to talk about, nor were we allowed to disclose this gag clause in the New England Journal of Medicine. And it turned out a couple of weeks after this was published, I got this note from the plan: pursuant to your agreement with US Healthcare, which has since been renamed Aetna, you may recognize that name rather than Aetna, you're fired. So if you collude, you can make a bundle, and if you don't, you can get fired. There's a fair amount of data that they do evict or manage to evict patients who use expensive care. So if you've had a hospital stay, you're much more likely to leave a Medicare Advantage plan in the next year. If you've had a rehab or nursing home stay, and if you've had home care use, you're likely to get ejected. So these are the incentives we've put into our healthcare system. And these plans don't save money. They actually cost Medicare more than it would cost if those patients remained in the fully public Medicare program. that is not funneled through private managed care firms. This is a sophisticated econometric analysis. And basically what it shows is that the Medicare Advantage plans on average save about $64 per member per month in medical care costs, but they cost about $125 per member per month extra in overhead, profit, and administrative costs. So they cost Medicare $47 per patient per month more than if those patients had stayed in traditional Medicare. And if you look at the overhead of Medicare Advantage versus some of the others, you see that the average patient now brings about $2,400 in overhead alone to a managed care firm. Under Medicare, $852 of our Medicaid HMO payments go towards the insurance plan's overhead. Now, this whole line of research was started by a conversation with Judy McCormick. Judy was an African-American woman who was a secretary at Highland Hospital when we were interns and residents there. And Judy actually ran the training program, though she didn't have the title of running the training program. But Judy said to us one day, you know, this place is very strange. When I started work here 30 years ago, there were 2 secretaries and 4 administrators and 600 patients. And by the time we were there were about 60 secretaries and 75 administrators and 250 patients. So that started us thinking, gee, what's going on here in the healthcare system? And we tried to put some numbers to it. And we looked around at other countries that we might compare ourselves to. So it turned out quantitatively, Judy's observations were exactly correct. If you look, for instance, at the number of physicians in the healthcare system over time and the number of administrators, physicians shown in yellow, by way of disclosure, we've actually faked that, because if we put the real data in here, you wouldn't be able to see it on the graph. The number of administrators is shown in blue here, and we've had an explosion of the administrative side of healthcare, which is really managing finances, not managing patients. So, we took advantage of Judy's observations to get ourselves published in a series of articles that have appeared through the years in the New England Journal of Medicine, this comparing the US with Canada. And if we look in the latest data in the 2 countries, the healthcare costs in the 2 countries are about $3,200 per person difference. So we spend $3,200 per person on healthcare more than Canada does. We spend $3,280 more per person on healthcare bureaucracy than Canada does. So that's the insurance overhead, and it's the costs of financing hospitals in the way we do, and the hospitals showing avarice in the way they do. We've looked at this in a number of nations, comparing the US to 7 other nations, and find similar kind of differences. Just to make this concrete, you know, Duke University Hospital with 957 beds has 1,600 billing clerks, and the billing cost is $99,000 per primary care physician per year. So when that bill gets sent out, a good piece of it is for the billing department alone. When we first started looking into this, we visited Toronto General Hospital, roughly the same size and range of specialties as Duke. And Toronto General had 2 people in its billing department whose job was to send bills to Americans who wandered across the border. And we've looked at this through the years. This is sort of one more recent one, caused us to look in detail at Canada's system and really get to single payer as the best solution to what ought to be done about our healthcare system. Canada has a simple program that provinces can get federal funding if they meet 4 criteria. They have to cover everybody, and the language says in a way that does not impede either indirectly or directly by charges or otherwise reasonable access to care. And that means no co-payments, no deductibles for covered services. Portable benefits, so if you're from Ontario and get sick in Quebec, you have to be covered. Coverage for all medically necessary services, which the feds have never defined. That means effectively all hospital and physician services, which was what was essential, deemed essential at the time the program was implemented in the 1960s. They do not have universal drug coverage or dental coverage, and they need that. Publicly administered through a nonprofit program, which came because of early experience in the province of Saskatchewan, where they tried subcontracting to a private insurer, and it cost 3 times as much as running it as a public sector. Well, now for some reason I'm not able to advance my slides, Stanley. Oh, there we go. So moving from the Canadian model, we published in the New England Journal back in the late 80s proposal for single payer reform, and a similar proposal subsequently in the Journal of the American Medical Association, and subsequent proposals since then. Steffi mentioned that she worked for Bernie Sanders. We actually drew up the first of his single payer proposals that was introduced in the Congress, and one for Paul Wellstone, and have continued to be active in advocating for those ideas. The alternatives actually come from very different roots than Canada's or universal health insurance program. And Canada's would be a disappointing TV program if one tried to base the Breaking Bad series on it. You know, Walter White got into crime to pay off his bill. It'd be a very brief series if set in Canada. Medicare for All really comes off the idea that Medicare is a simple program if you throw out the managed care firms that have come to take over a big piece of it. This is the Medicare software that signed up 18.9 million seniors within 11 months of the program's passage. The first person enrolled in Medicare was Harry Truman. They enrolled seniors by sending everybody registered with Social Security a postcard, and sent out agriculture and forestry agents into rural areas to reach difficult to reach persons, and contracted with inner city poverty programs to reach those in the inner city. All the alternative from the Obamacare program is illustrated here, and the Republican plan, Get Sick and Die Penniless. The ACA, unfortunately, has its roots in Richard Nixon's 1971 proposal, which was advanced to try and block Ted Kennedy's plan. And it is almost identical to what Obama ended up proposing, and was in 1980 proposed by the Heritage Foundation, and in the early mid-90s by Mitt Romney when he was governor of Massachusetts, and then became Democratic Party policy. And it's an expanded Medicaid-like program, largely administered through private insurers, subsidies for low-income person, buy-in without subsidies for others, an employer or individual mandate, and insurance exchanges to help people buy coverage that rather than themselves navigating the thicket of insurance bureaucracy. Well, Canada's experience really shows us some of the advantages of a fairer and more efficient program. So this is change in life expectancy over the last 5 decades, and you see each of the income groups in Canada has gained, not as much equality as one would like to see there. But the poorest 20% in the US actually has lost ground in life expectancy, while the richest have gained spectacularly. So we've been going the wrong direction. Canada moving towards greater equality. Cystic fibrosis patients, carefully studied not by us, but by others in both countries, and adjusting for all markers of severity of illness. Canadian patients have markedly better survival than even the privately insured in the US, and tremendously better than uninsured CF patients in the US. So an illustration of those needing expensive high-tech care in Canada. Health costs, which were almost identical as a percent of GDP in the two nations before they implemented national health insurance, quickly separated and have remained far lower in Canada than ours. If we look at public spending in the US, which is shown in yellow on this slide, we spend more in government dollars per capita than total spending per capita, which is shown in blue for all these other countries. in any other nation. So we spend more in government dollars than any nation spends on its entire healthcare system. And of course, in addition to the government money, we throw in additional private dollars. It's not that that Canadians don't see physicians. In fact, people in other countries see their doctors more often than we do. They get more hospital inpatient care than we do. It's not that we're expensive because we have so many old people in this country. Other nations are older than we are. It's not that we have so many immigrants taking our healthcare services. Other nations have more immigrants as a percent of their population than we do. What we get an extraordinary amount of is insurance overhead, more than $1,000 for every man, woman, and child in our country goes to an insurance company for its overhead. And the overhead, which I've really shown before, extraordinarily different. I'm just going to skip to the ending, which is to show you I haven't completely lost touch with reality. This is the view of Boston as seen from our home in Cambridge, Massachusetts. We still maintain a little pied-à-terre in Cambridge. And the two tallest buildings there are insurance company buildings. So the fight for national health insurance is a fight to take the money away from these folks and give it to people who actually need it. But if you ask the American people, what do they want? And this is a Commonwealth Fund Harvard Public Health School survey from last year, 60% support a single payer national health insurance system. The question was, do you support or oppose changing our health system so that all Americans would get health insurance from Medicare paid for by taxpayers, often called Medicare for All? So we know that it's a popular program. It's what the American people want. The question, I think, is, can our democracy actually deliver what most Americans want? So I think we've left at least some time for discussion and questions, and we've covered a lot of ground. Certainly said nothing controversial, so I can't imagine that anyone would have any different.
Oh, wow. This is just so sobering and overwhelming. And I want to make this mandatory curriculum for everyone at UCLA right now. So we will be using the recording from this session.
Okay.
We have a couple of great questions already in the chat, and I encourage you, if you have additional questions, put the hand raise icon up. The first question is, appreciate your important work over the years in research and advocacy. A couple of questions. Might it be useful to frame the US healthcare system not as failing, but as working as intended, transferring wealth upwards and enforcing precarity on the lives of regular folks? And then a second question, what's the route to achieving single payer short of rewriting the US Constitution? Pretty big questions.
Well, the answer to the first one is yes. You could reframe it as, if you have a profit-oriented system, it creates profits. It incidentally might help health, but not much. You don't need to change the Constitution to get a single payer. It's something that Congress could pass, under existing law. Perhaps this is a reference to the Supreme Court and the structure of the Senate, but certainly if there's a popular movement that forces Congress and the Senate to pass something, then it can happen. And, we actually got reasonably close in the last couple of election cycles to building a movement that put forward a single payer candidate. For a while, it looked like Sanders was going to carry the day. Obviously, that he didn't. But we weren't that far away from having that kind of strength, and we need to be focusing on building that movement.
Yeah, we often show in one of our classes a slide of Lyndon Johnson when he was senator from Texas, saying that he was a firm supporter of states' rights and of racial segregation. And then the video of Lyndon Johnson 5 years later giving the speech at the commencement of Howard University, announcing affirmative action as national policy and saying we need to create not just equality as a theory, but equality as a fact on the ground. So I think the route to it, frankly, is through the streets, and the politicians will get the message if we have a powerful enough movement. Now, you have in California a single payer bill which is in committee in your legislature right now. And moving on a state forward would be a tremendous step.
So actually, that was the second question in the chat about California and Vermont proposed initiatives, state initiatives. And so a follow-up question is, can a state successfully set up single payer without federal support? How would that work?
You're going to have to get some federal enabling legislation because you need to fold Medicare into your single payer, and you need to fold FEHBP, the federal employees, into it. So you can't have it if the federal government is completely and totally opposed to it, but you can really move things forward at the state level. And if you have the power to actually pass something at the state level, then you probably have the power to get the federal enabling legislation you need.
And the Vermont experience, I think it's been misunderstood. I unfortunately got into a very unpleasant exchange with the governor of Vermont when they were considering their program. And I told him he had a poorly designed, poorly thought out program that could never succeed. And he took that as undue criticism, but I think it proved correct.
So just to follow up on your point about state versus federal law and enabling those, I am wondering what, and you also mentioned that what we have to do is take to the streets. You're speaking to a group of many clinicians, many people involved in healthcare directly, and also this is a group of people who may do social scholarship, maybe in the Department of Education, even in the World Cultures program here. And so it's a diverse group. But I'm wondering, what could you envision for us as actors in this doing to advance the vision that you've put forward? Because it's a very big shift that's required, and we're working against the grain of neoliberal thinking worldwide, but it's so vital. This is life-saving, this kind of movement.
Okay, well,
what can we do, people like us?
We should be thinking in our scholarship, is the scholarship going to be useful for social movements? And there are social movements out there right now. And, is our scholarship useful? But we also need to be moving in our own professions forward. So we need to be moving physicians forward. We need to be moving teachers forward. We need to be moving academic thought forward. So those things are important. They're not worthless to tell teachers and inform the education community about inequality, about healthcare, about the way healthcare falls into other social determinants of poor educational outcomes, let's say. So people need to be working where they are to move the discourse and move their own professional group forward, with an eye toward informing social movements. But that's not the only thing to do. We need all sorts of segments of society, professional, academic, et cetera, to be rethinking and moving on these questions.
Yeah, the AMA came within 2 votes last year of rescinding its opposition to single payer, and moving that organization, which we will probably be able to do over the next 5 years, would be a huge boost to the social movements. And the point here is not that we all need to do every piece of this, but that scholarship needs to be part of it. And I would say it's not that we need a single payer movement separate from those addressing the other inequities in our society. It needs be a component of a movement addressing racism and addressing class inequality and oppression of workers and climate change and the broad changes we need in our society.
Well said. Given the economic centrality of healthcare, it's probably the single largest sector of our economy and one of the largest employers. If we want to do equity work, it makes sense to start there.
Yeah, I mean, it's the largest employer, for instance, of African-American women in the country by far.
Mm-hmm.
So the racism in the healthcare system is critically important.
Yeah. It's a major cause of what the economists called unsecured debt. So if you have secured debt, like buying a house, often that's a way to build wealth. But if you have unsecured debt, like medical debt or borrowing against your credit card, that detracts from your wealth and well-being. So it turns out the healthcare system is a major component of unsecured debt in this country. It's the most common item on your credit reports. If you have a ding on your credit report, 50% of the time that ding is going to be a medical debt. So it really does feed back onto all the other social determinants that we do think drive ill health and poor social outcomes generally.
Thank you. So I have a couple of other questions here. One is, I wish Medicare for All would take out all the insurance companies and that producers of medication started offering them for the price that they are. What about producers of medications offering copay assistance more often? It boggles my mind that when paying for a PPO, my medication skyrocketed and I had to ask for copay assistance. And because time is short, I'm going to bundle that with a second question, if you don't mind, which has to do with the VA. Is the VA a good model of single payer system? Should we be pushing for VA for all?
Okay. First, the way to attack drug costs is to give the government the right to negotiate, which they have in most of the rest of the world, which is why the rest of the developed world pays drug prices half of what we pay in the United States. But there's specifically in law something about Medicare can't negotiate prices, which Congress stuck in there. So that's the way to go, not playing games about individual co-payments. The VA has so many good features. You know, it's got very low co-payments, very low deductibles. You know, it's an integrated primary care system. In a lot of ways, it's a good model. The problem with the VA is it's very closely tied in with military culture. And for many of us, that's not a very comfortable model. But certainly in terms of the healthcare it delivers, in terms of the affordability, it's a very good financial model.
Yeah, not much local control, which we need much more of in the healthcare system. The other thing PNHP has proposed is that government shouldn't just be a purchaser of drugs, it should be producing drugs. So there is actually already under federal law, the president has the right, if a drug company isn't offering its vital drugs at a reasonable price, to abrogate the patent and use what's called march-in rights to have it produced either by the government or by another organization. We need to do that more.
Thank you. And so hopefully we have time for at least one more question. Historically, corporate interests have been the major roadblock to single payer, i.e. a well-known product of neoliberalism. In today's political atmosphere, fake news and political echo chambers are a major challenge. Is our discussion of neoliberalism outmoded? Should we be discussing the major roadblock to single payer being surveillance capitalism? In other words, capitalizing on personal opinion to feed people back what they want to believe.
Okay, well, I think surveillance capitalism is a huge issue that we very poorly understand. I think the sort of rhetoric that people do understand is like the billionaires running everything to make profits. That's similar language to the neoliberalism, or similar meaning to neoliberalism, but different language.
Could I just tack on one question to that? In your travels, what have you seen are the potential footholds among, voter and potentially politically active constituencies outside of medicine? So, for example, when we talk about elites and the concentration of wealth and what relationship that might have to healthcare costs and structure, what do you see on the horizon as some potential footholds with elections coming up and all of that?
Okay, just a couple. We've worked a lot on debt because 20% of households at any given time in the United States hold medical debt. So that's an almost universal experience among working families, that at some point they or someone they know has gone into serious debt because of the medical care system. Obviously, there's a movement around debt, mostly around student debt right now, but there is a social movement there. There's other issues like actually the fairly good news that came out, which is Medicare didn't approve this new Alzheimer's drug except in clinical trials, Aduhelm. Aduhelm had raised Medicare Part B premiums by almost 15% because the premiums had gone up in anticipation of paying for this wildly overpriced Alzheimer's drug that probably doesn't work. So when the FDA just, not the FDA, I'm sorry, this Medicare coverage determination said we're not covering it, that meant that you could lower the Medicare Part B premiums. Again, a more or less universal burden on people over the age of 65. So there are pressure points if you, within the, thinking about healthcare within the larger voting community.
Great. Let me just ask you, do you have the flexibility for one more question for those who can stick around a couple more minutes? Okay. Sure. The next one has to do with movements against single payer that allege that quality of care is lower in Canada and other places with single payer. And so the question is, how could that be addressed?
Well, it can be addressed. I mean, it has been addressed and should be addressed more with data. The kind of data we showed a little bit of, there's somewhat more than that available as well. So for instance, heart failure patients have been studied, do at least as well, probably better in Canada than the US, and care of MI patients. So I think as scholars, we can actually look at some of that and help to defeat that, but that data then needs to get out to the public, and so it's not enough to publish it. It needs to be disseminated and campaigned on. So when folks tell lies, we need to have a cadre of people prepared to answer them.
Yeah, and I think that's some of you guys, right? That's what you can do. One of the things you do with research is you say, well, actually the research says something different. So certainly working through the media is an important part of good scholarship, good social advocacy through scholarship.
I mean, we learned that very early, at the first point in our career when we did that study on patient transfers in Oakland, and we went to the Oakland Tribune and we made an estimate for how many people were being denied care in Alameda County and what the implications were, and that actually went viral. So it's not enough to do the research, you actually need to let people know about it.
Thank you so much. This has been fantastic.
Thank you. Thanks for having us.
Great questions.
And we're so happy to be in LA instead of in Boston with this.
All right. Have a great afternoon and weekend to those of you who we don't see again.
Thanks for joining, everyone.
Thanks.
Oh, and also I should mention in 2 weeks, we're going to be meeting with fundamental cause theorist, who is Bruce Link from UC Riverside. So join us for more in-depth dive in social determinants of health.